Do you have any thoughts on what a lot of patients seem to be doing, which is, taking the smaller doses for a long period of time, 32 to 65 milligrams, instead of the, 300 to 500 milligram range?
Yes, so I think that's a very, very effective way of increasing the dosage is good actually, because we also see a lot of uh, gut and colon related issues with borreliosis, and because of the systemic inflammation, so they have a lot of problems in the preclinical model. At least the hypoperfusion problem need to be fixed. A perfusion need to be back to normal, then only you can treat different part of the brain, right? If you have a hypoperfusion and still you deliver something, it may not reach the places where you need to go. I think by low doses, we are fixing our systemic and also the brain vasculature. That's what I think. Once the perfusion issue is addressed with the low dosages, and then with higher dosages, maybe it is doing whatever it is doing in this patient. Again, nobody knows why they are becoming better. I think both Dr. Kenneth Lehner and Dan Lehner, so what they found out is very interesting. By their observation, they found out this graded dosing is much, much better than, giving the full dose at once. And that's a very interesting observation.
You said greater dosing, you meant lower dosing is better, right?
Yeah, lower doses then ultimately get into your efficacious dosage.
Is reaching a consistent blood level of disulfiram in the body more important than the dosage or the amount?
Even lower dosage of disulfiram helps to fix the issues which Borrelia caused in this preclinical model we observed. So if you translate that to human, it's likely to, even low dosage can help them a lot, and then prepare them for high dose so that the drug perfusion is much, much better when you increase the dosage slowly.
I guess the question is it bad to be constantly stopping and starting, stopping and starting? Is it better to just be on a very slow, gradual thing where you don't have to constantly stop and start?
I mean, I'm not supposed to give this advice. You
Okay.
can ask your clinician.
If low doses can get to all of the cells, then why do you really need the high doses?
No, the low dose, as I mentioned, it can fix all this perfusion issue. But the high dose obviously needs to get into, if there exists an infection, it needs to clear the infection. That's what we think.
So could it be possible that the low dose may be addressing the chronic inflammation, and then the high dose is what actually exerts the borreliocidal effect?
Based on our preclinical work, we think that's what's happening.
So you actually have two things going on. One is the anti-inflammatory effect, which can be achieved with a low dose, and two is the anti-borrelia or borreliocidal effect, which requires the higher dose, is what you're saying?
That's correct, yes.
Are high concentrations of disulfiram required to effect a cure of Borrelia in the mouse model? And by what conversion factor would that have to be multiplied to kill Lyme in a human?
The way a drug get exposed to different parts of the mouse body is different from human. In fact, humans, we have a better drug exposure when compared to mouse. So you wanted to do the calculation how much drug need to be delivered for 100 kg person. It is not 50 into 100. It is 50 into 100 divided by 12. We are 12 times more efficient than mice. So that means you need 12 times less drug that is needed for humans. So it is 50 into 100 divided by 12, which is basically manageable concentration. Now, another thing, when we publish a paper that we never titrate it, let us say, whatever the drug concentration is. The question we ask when we deliver either an IP injection or an oral injection, whether this particular molecule is killing Borrelia in vivo system. It's a very simple question. And then we have to start some concentration. We generally start at higher concentration because we think higher concentration, higher possibility of killing Borrelia. That may not be the ultimate concentration a human is needed. So it's also not correct. Just looking at the paper of somebody did some mouse study and then try to calculate and then come up with an understanding, whoa, I need to take so much. No. So that we are yet to do. In that paper, whatever you see, we just asked one question, whether it is efficacious in, optimally clearing the Borrelia. And then the another question we asked is whether it is immune protectant. It's not causing any kind of immune dysfunction. So these are all the two questions we asked, and then we answered it, and then we put it in the web for greater benefits of the people, audience. But again, we need to titrate it. So whatever number you see, don't take it. As I mentioned repeatedly in this conversation, your clinician need to identify the proper dose and how to deliver to you. It's particularly need to be in a careful, monitoring by the clinician. Nobody should self-medicate themselves using any therapy, not only this one.
While there seems to be an emerging consensus regarding going low and slow with disulfiram, I think we see a lot of debating regarding target dosing and duration. Does Dr. Rajadas and his team have any insights to share regarding target dose and duration for disulfiram when delivered via enteric capsules? I know that many clinicians, including mine, are using the target dose developed by Dr. Liegner, which is weight-based, 250 milligrams for a 100-pound person, 500 milligrams for a 200-pound person, etc., for approximately 90 days. But from what I understand, that was developed based on Dr. Liegner's experience using off-the-shelf antabuse, not the supposedly more effective enteric-coated capsules. The sub-question is, of course, around staying at a lower dose for a longer duration versus getting to a higher dose for a shorter period of time. I'm well aware that the human studies have not been conducted, but perhaps there are some insights that can be inferred based on what they've learned from the animal models.
So again, it is your responsibility to advise your patients. It's nobody should take any insight from that. The clinical trial we are now designing, we just go with Dr. Kenneth Leiner's advice. We think that is the most effective way of delivering for a total clearance. And he is also advising us continuously in the trial design and all. Whether it is encapsulated or direct antabuse, the amount it seems to be the same as Dr. Kenneth Leiner recommended.
Definitely. From the mice that you treated with disulfiram so far, can you tell us approximately what was the average time to see an improvement in symptoms once they began treatment with disulfiram?
Again, that experiment we need to do, like for example, we need to do experiments of 8-hour exposure, 1-day exposure, 2 days exposure, like that. We didn't do that experiment yet.
And you also don't know if the mice initially worsened in their symptoms before they got better.
Yeah, that I think we have some idea, because obviously, as I told you, acetaldehyde level is going to hype up. When the acetaldehyde is very high in these animals, they are not very comfortable, at least for some time. Like, one thing is for sure, Borrelia need a longer drug exposure when compared to other bacteria, because they takes long time to divide, and also generally we expose them for longer period, even in the culture actually. Yeah, we are ready to do the titration with the time also, like increase or decrease the time and then see whether how effective disulfiram is clearing the Borrelia. We are to know that.
The diethyl dithiocarbamate appears to be abbreviated normally DETC, in case anyone was wondering. Do you know what the known half-life of disulfiram is? As apparently there are different articles on the internet saying different things.
So what we decided not to commit anything, because there are a lot of variations. And also, whatever we do it in rat and mice, it appears in human, it's very different. So what I did is last week I wrote a small grant and applied to a foundation. I can just recruit 20 human volunteers and try to do very thorough pharmacokinetics. Actually, both a slow delivery formulation we developed and also the anti-abuse. And that data will be very, very valuable data for our upcoming clinical trial.
So you actually don't know in humans what the half-life might be.
We don't know. Like another problem, we need to be addressing very soon. People with chronic inflammation, in the way they metabolize disulfiram and compared to normal people. So we need to figure out all these things.
So if you don't know what the half-life is, then we don't know when it would be safe to start consuming alcohol again after you stopped the drug, right?
They say about few weeks after that you can start taking the alcohol after you stop it, few weeks. In fact, in the Antobis website itself it is there.
Is there any known reaction between grapefruit juice and disulfiram, as they both utilize the P450 cytochrome pathway?
Any acidic fruit juice likely to increase the degradation. You are not supposed to take it with acidic food actually.
Would taking disulfiram alongside sodium bicarbonate to help neutralize the stomach acid help to avoid the copper complex issues?
Yes, that's a good approach. Yeah.
Do you think that supplementing with zinc or molybdenum would help reduce copper levels?
We just started those experiments, but I think so. But with the zinc, I don't know about molybdenum. With the zinc, it's likely to reduce because zinc can nicely form a very good complex with degraded disulfiram. So that kind of makes copper complexation ligand unavailable. So yes, the answer is yes, but I don't know about molybdenum.
Anything to say about glutathione?
The degraded form of disulfiram that binds very well. In fact, covalently linked well with glutathione.
And do we know if that's a good thing or a bad thing? Will it affect the efficacy of the drug?
We don't know the good thing, or maybe it is a good thing. We have to measure, we have to take a glutathione adduct of disulfiram and inject to the animal and then see any bad thing is happening to these animals.
Okay. Along the same lines, N-acetylcysteine is often taken as a supplement to boost glutathione. So if we don't know if glutathione is good, we won't really know if NAC is a good thing to be helping.
That's correct.
Is there any reason why disulfiram would be unsafe for children under the age of 12?
Oh, that's a dangerous question. I don't want to answer this. The pediatric clinician need to answer this question.
I know we talked about this last time about the biofilms. Do you have any idea on whether or not there is a specific molecule? Someone mentioned carbon disulfide.
Kenneth Lehner mentioned about it. Again, I don't know.
Okay. I always wondered this about the brains of Lyme disease patients. Do you think that they have excess beta amyloid levels?
We have some data. We didn't publish, in fact, in the Journal of Neuroscience paper.
So at least in the mice studies, do you see excess beta amyloid productions in the brains of Lyme disease infected mice?
I will share the paper. It's a good question. We already completed. I will share the paper. There is a molecule called secretase, and these secretase are involved in beta amyloid production. People show disulfiram inhibits that pathway. That means disulfiram, even without anything, is likely to reduce the beta amyloid load in the brain. That's a good thing, actually.
Is beta amyloid typically removable or reversible?
Beta amyloids, if they accumulate too much, they form sometimes, even aged people, you have a lot of beta amyloid aggregates, but generally they don't form a toxic aggregates. But in Alzheimer patients, there are data, I myself have a lot of papers on it, that it is toxic, especially people having Alzheimer condition going on. For a Lyme, it is true that slightly it increases the beta amyloid production because of the oxidation that is going on in their brain. That level of increase, we call it as an amyloid cascade. That is not enough for an amyloid cascade. So it's still reversible.
Is it known if disulfiram is a mast cell liberator or a diamine oxidase suppressant?
Yeah, there are some nice published work on it, on mast cells, on disulfiram. I will share those articles.
One person was asking whether or not it goes into the bone marrow, which apparently is where Babesia can reside.
Yes, it can go into the bone marrow because the lipidic content in the bone marrow is very high. And if it gets into the blood-brain barrier, it can also get into the bone marrow. Maybe in our next manuscript, there will be one figure to show bone marrow level of disulfiram.
Do you believe that disulfiram kills the pathogenic strains of Babesia?
I do believe that, yes.
And do you know what the mechanism is for that?
Disulfiram got a very good absorption in the red cells. And Babesia, the parasites generally, it has a kind of similar mechanism of absorbing the disulfiram to its membrane. Disulfiram is also effective against some of the pathogens similar to, Babesia. And I think it's likelihood that it get cleared by treatment with disulfiram. Dr. Kenneth Lehner introduced me to your collaborator to initiate the study with Babesia. So maybe we will have an answer soon. A lot of activities. Now we are entering into Bartonella and Babesia because of interest. Joseph is interested, and a lot of my collaborators, they initiated this.
Have the mice studies shown any viral reactivation symptoms while taking disulfiram?
No, we didn't ask those questions actually. It's a good question.
There is some evidence apparently that disulfiram reactivates latent HIV infections. And
that's correct. But that trial, I think somebody told me it is stalled because of side effects. There is a mechanistic paper on it, but that's not my area, so I don't know the answer. But I can share that paper with them.
Any idea on whether or not disulfiram could treat Ehrlichia or Coxsackie virus?
I don't know about it.
Do you have any idea on whether it would kill other parasitic infections or worm infections?
I don't have any idea. But one thing for sure, what we found out, this immune activation, immune protection, they are going to have a good immune functions after this treatment. So likely they themselves get cleared. Again, I'm not a clinician. Their doctor need to advise them. You listen to your talk. Everything need to be properly vetted by your clinician, and then you need to listen to them.
One person asked if disulfiram kills relapsing fever infections.
Yeah, it's likely to. We think it's a kind of non-specific mechanism, the way Borrelia is getting killed.
What about Rocky Mountain spotted fever?
Maybe, yes. I have to do experiments. Yes.
Q fever or anaplasma?
Those kind of things is not my area. I don't know.
So same thing for mycoplasma, you're not sure?
We are not sure, yes.
Do you have any insight into whether or not disulfiram can kill Candida?
Yeah, so there are papers talking about antifungal activity of disulfiram. Perhaps it is killing the Candida, yes. So what we found out, any chelator, it's likely to reduce the iron content that improves the survival and the better function of the transplant in this both animal model, and also we correlated with the human. I think in that context, it's likely to be a great antifungal molecule. It's likely, again, as I told you, like we need to do experiments.